has been working on specific legislation as well. So I'll be going through an overview of how adult social care work in UK. So so each local authority is responsible for managing social services in their area. When we say local authority, probably in back home in our concept, it can be considered as panchayat or municipalities. So there are many local authorities in UK, England, Wales, and Scotland as well. So each local authority has a particular number of population living there, and the local authority has the responsibility to look after people's care and support needs. Okay, so there is a financial threshold included in that. So for example, if somebody has a saving over 23,250, probably they might be known as the self-finance people, self-funding people. It means still local authority has the responsibility to assess their needs, but they might be responsible for financing it. Okay, but compared to general population, there are only less number of people who will be known as self-funding. Okay, so most of the population, when they have care and support needs, they will be referred to adult social service when they are over 18, and we will be doing assessment. Okay, this include any people with a physical disability who need care and support. It can be older people. It can be people with learning disability. It can be people with autism, mental illness. So for example, if people have any need, physical needs or mental illness, mental health needs arise from any particular diagnosis. It can be mental health or physical health, and if they need care and support needs, then local authority has the legal responsibility to conduct social care assessment under Care Act 2014. And also it is local authority's responsibility to safeguard people who are at risk of harm or abuse. So when it comes to the structure of social service, so the structure might vary, but generally there is a senior leadership team which consists of CEO, directors, assistant directors, and service managers. They overview the management system, senior leadership system, the liaising with the central government, the funding aspect, overall funding which local authority would get, those kind of things they will be managing. We need to proudly say that there are so many Malayalis workers, directors, and service managers in each local authority as well. When I say so many, it's not massive number, but there are significant numbers working as well. Then is come to team structure. So there are so many teams, which I will explain a little bit later. But in team structure, there are team managers. They will be the people who will be responsible for managing the social work team. Most probably, team managers are social workers as well. Then we have senior social work practitioners uh, who are kind of managing and supporting and supervising experienced social workers and newly qualified social workers. And also underneath the social worker, there are professionals called, they are not qualified professionals in social work, but they have basic qualification like level 3 or level 4 in health and social care. They also work along with social workers. They're known as assessment and enablement worker, care coordinator, care managers, or assessment workers. So that's how an adult social service look like. So in each team, probably you will have 25 to 35 team members. Among them, there are business support officers as well there. So there may be around 10 social workers in each team, if we ask roughly. Okay, so there are many social workers working in adult social service across many teams. So let's look which are the team, generally working in adult social service. When I say this specific name, each time local authority is going through restructuring because they believe in kind of, essential change. So whenever they feel like the structure need to be changed, they may change the team name. But these are the team name, specifically used across all social services. But there are changes in other local authorities as well. Okay, one of the team is known as transition team or moving to adulthood team. That is the start point of the team where children has been cared by social service with children team when they are transitioning to adulthood, when they become 18. So there is a specific transitioning team who would support them to have a smooth and gradual transitioning to adult team, because they might need continuing support in adult team. So that team is known as transition team. Probably people start to work with social workers, start to work with children with care and support needs when they transitioning from 16 onwards, though they have a allocated social worker until 18. That transition start from 16 and generally moves until 23 years old. Okay, then there is an emergency duty team. Every local authority has an emergency duty team that's working 24 hours 7. So that is where, for example, in weekends or after 9 to 5 working hours, if there are any emergency cases comes in, they are the people who will take the phone calls and arrange emergency care or support if needed. Okay, sometimes there are specially assigned front door team also working Monday to Friday as well, where the referrals comes through. Then there is a physical disability team. That team is specially dedicated for people who have physical disability and has care and support needs. When I say care and support needs, that's the terminology used in adult social service when referred to the people who has care needs. Okay, physical disability team, it can be brain injury, it can be any physical illness, and they are unable to meet their care needs. Then there is a specific learning disability team. Every local authority has a specific learning disability team because there is a reformation and change for the integrated approach, because there have been a case review previously where people with the diagnosis of learning disability has been institutionalized for a long period of time without having review. Since then there is a specific dedicated team for supporting people with the learning disability, which they are closely working with health as well. Then there is older people's team. Older people's team means the team which support people over 65 years old. They will be dedicated to support people over 65 years old. Then there is a safeguarding team. Every team has the safeguarding responsibility. Every team will be doing safeguarding, but in some organizations, some local authority, there is a specific team committed towards it, which they would manage safeguarding inquiries related to institution. For example, if there is a safeguarding inquiry in a care home or supported living or supported accommodation, and they will be expertise in guiding safeguarding investigation. I know that we have expertise delivering about safeguarding. Then we have care quality and commissioning team. That team is specifically function around institutions, domiciliary care agencies, care homes, supported accommodation. They will ensure the quality and contracting of each organization within the local authority. Then there is a mental health team. There is mental health team as part of adult social service, and also there is mental health team dedicated as part of NHFT and NHS as well. As part of adult social service team, social workers and professionals who is trained as AMP, adult mental health practitioner, they will be working in mental health team. Okay, so when you're considering back home situation, I know that there is a mental health act in India, but specifically if somebody is unwell, mentally unwell, they are unable to consent for the treatment, and they definitely need a treatment in a psychiatric setting. Though they are unable to consent, there is a process involved with them. Okay, which we need to practice least restrictive option, and we need to ensure that that has been done fairly. So there is so many assessment process under a specific legislation. When it's come to mental health, it comes under mental health act. So there are social workers working there as well. Then there is a care home review team where people are placed in care home, care home that related to assessment and review. So there might be a specific dedicated team. Then there is a dedicated hospital discharge team. For example, if somebody is admitted in hospital and when they are returning back to home, if they need support, for example, they might need some support to kind of with the home adaptation, Okay, so they might need to liaise with OT, they might need care package when they go back to home, or they might need to discharge back to reablement or care home. So whenever somebody is ready to discharge from hospital, and if it's been identified that without support it is unsafe to discharge back home, hospital discharge team involved for the assessment. Social workers work in that team as well, and it is a fast paced team and a very interesting team. Okay, so generally, though there are so many teams work in social service, we all work on a particular number of legislation, and assessment framework are same, though the team has specific functions, and people move across the team internally. For example, I started to work in transition team. I worked there for 2 years. Then I move across learning disability, older people, safeguarding. So people move across different teams when we work. Okay, so I just want to update you about the new changes as well. Some of the local authority has been updated the new changes because they think that when we work in a particular team name, people are struggling to identify adult social service function, and local authorities are working as a separate entity. So according to the integrate approach and new working pattern, local authorities are trying to work in a postcode basis. For example, in Northampton and some other local authorities, they have a specific team working in each postcode. For example, probably NN1, NN2, one specific team will be dedicated for it. So regardless whichever team it is, they formulate as a one team. Okay, and that one team work within the community. So that approach is mainly about they are aware of the community resources, they are aware of what is working in the community, and they believe in people will be more independently functioning within the community with the informal support network. So whenever you are preparing for interview or reading and research, you need to be aware of this new change as well, because most of the local authority relying on this traditional team structure, but however some local authority has moved with more integrated approach. Okay, so I hope that you have got a kind of overview of the name of the team. So don't worry if you can't remember the names of the team. Whenever you say job vacancy or whenever you've been interested in working particular team, you will see what that team is specifically aiming for. Okay, then we need to understand, what is the role of the social worker. Okay, whichever team we are working in, as I said before, our main involvement is around assessment. Okay, so assessment is always we probably back home in India or Kerala, you might have done many care need assessment, you might be expert in it, but in UK there is a specific framework for assessment, and you need to familiar with that legislative framework, that is Care Act 2014. We have separate section which would explain that. Okay, so according to Care Act 2014, that is based on well-being principle, and there are 9 eligibility needs and outcome. When we are doing assessment, we are assessing people based on the eligible needs, and if they fit into eligibility framework, it means they are eligible for formal support. So it is important to learn about Care Act 2014, that is the backbone of adult social service. Then there is another involvement, for very important involvement is for safeguarding, that also comes under Care Act 2014 under section 42. Okay, so safeguarding is whenever adult with care and support needs unable to protect themselves, there might be safeguarding referrals comes in. Okay, and it is all our responsibility to look into safeguarding issues. Social worker has the responsibility to complete inquiry of safeguarding with other responsible bodies, for example police and Marak, etc. Okay, so safeguarding, completed safeguarding inquiry, protection plan, support provision, also important role of a social worker. Then if you're working in a care home team, it is your responsibility to quality assurance of the care home, supported accommodation or supported living or domiciliary care. That's also the important function of social worker. Another role of social worker is completing mental capacity assessment. So mental capacity assessment, I think we will have a separate session. It's a very massive session, a very broad subject. Okay, so whenever feel like someone is unable to take a decision because they have a impairment or illness of their brain, definitely that need to be legally proved, because we need to adhere to some principle. Then social worker need to do a mental capacity assessment under Mental Capacity Act 2005. Okay, if somebody hasn't got mental capacity, then deprivation of liberty applies. So that's also one important area social workers need to understand, read, and develop knowledge into. Okay, then social workers are involved in court of protection. Sometimes court of protection is important because we are depriving people's liberty. So in court application and everything, social workers are involved. And when there is care package, or somebody's in a care home or in a domiciliary care. When I say domiciliary care, we need to understand that social service promote people to be independent at their family home. When they are living at family home, still they need to function in a particular way. They might need support. For example, somebody need to come in the morning and evening to wash and dress them, give medication, and meeting nutritional needs. So that is called domiciliary care or care package. So when we are putting that care package by a social worker, we need to ensure that care package quality and need might change. So that need to be reviewed as well. Or if the care agency is not that providing care appropriately enough by meeting the quality of standard, social workers are responsible for investigating this as well. Then social workers has role in mental health, for example, working with other organizations to support people, improve people's mental well-being. There might be social worker mostly involved in domestic abuse cases. You might need to work with the victims and promoting empowerment. You might need to support them to find refugees, and kind of referring and working with police to get restraint order, those kind of things as well. You might work with asylum, migrating from different countries. You might need to work with people with the hoarding disorder. uh, that is quite prevalent in the UK as well. Then you might understand what is hoarding. People might have tendency to hoard a particular item up to, can it lead up to ceiling level. That is a particular disorder, and the people need very complex and long term involvement to come out of this situation. You might be working with people who've been cuckooing, for example, cooking the drug line. Okay, and also you will be responsible for multi-agency working, because social workers are working with many other professionals. For example, housing, as adult social worker, you might be working with the learning disability nurse, you will be working with mental health professionals, psychiatrists, doctors. So multi-agency working also important role of a social worker. So these are the main roles when you work as a social worker, you will be encountering to and responsible to. Okay, so these are the legislation you need to underpin your practice when you work in adult social care. Without having thorough understanding of legislation, you won't be able to practice as a social worker. Okay, so it is really important to understand, read, and kind of practice according to this legislation. So as I've said before, Care Act 2014 is backbone of adult social care, and that is based on the concept of well-being. Then there is a Mental Capacity Act 2005, which consider people's mental capacity in each area. Then there is a Mental Health Act, when people need treatment and they are unable to voluntarily agree for the treatment, then Mental Health Act applies. Then every act is based on Human Right Act 1988. Okay, backbone of every act is Human Right Act. So people work here, social workers work according to Human Right Act, social justice, people's life for safe life, secure life, etc. Then there is Equality Act 2010, that is really important piece of legislation, because social workers are always working for social justice. That is the basic concept of social work. Okay, so when we are working for social justice, we need to work in an anti-discriminatory way, which would explain in Equality Act 2010. And another important just legislation is Data Protection Act and GDPR. That is mostly around how we safely share information and appropriately, and how we need to adhere to data protection and storing and sharing data. Okay, these are the main legislation we work in adult social care. So whoever is looking or trying to find a job, or trying to have a work opportunity in adult social service, you need to be familiar with all this legislation. Then you need to remember that social work is a value-based profession. Okay, so every local authority, when they appoint you as a social worker, they are expecting you to work in a value-based approach as well. Okay, so whichever approach, whichever interventions we are taking place in, that intervention need to be based on social justice, Okay, it means if people are economically deprived, or if people are deprived because of their particular diagnosis or in a marginalized area, we need to work and we need to fight against social injustice. Okay, we need to be working on anti-discriminatory practice. That is the greatest terminology always used in social care and interviews as well, and in an anti-oppressive manner. Anti-discriminatory is related to people are not supposed to discriminate based on protected characteristics. If you are referring back to Equality Act 2010, there are 9 protected characteristics, which comes with age, disability, ethnicity, sexual orientation, pregnancy, those kind of things, race, etc. So we are not supposed to discriminate people according to that. We might have a strong value based on our culture, where we born and brought up, for example, same-sex relationship or same-sex marriage or those kind of things. However, as a social worker, we should be committed for anti-discriminatory practice, and we shouldn't be making any comments in social media or whichever platform you share, so that could put into your social work reputation in question. Okay, then we need to practice in anti-oppressive. Anti-oppressive is some societies being oppressed because of a particular reason. It can be because of their religious reason, or it can be because of the economic, or it can be migration reason. So we need to work in an anti-oppressive way as well. And this is also known as inclusive approach as well. Another approach we need to think is people are expert in their life. Okay, I know that back in Kerala, where we practiced and born and brought up, there is a high power differential, where government authorities or people who work in government jobs seems like they are the people who kind of provides provide, or they have the authority to give a service and is on their mercy. Here the concept is completely different. We are serving people. Okay, most people are aware of their lives. So whenever we are doing engagement intervention, even when we are writing reports, the terminology we use need to indicate that people are expert in their life. We are not expert of their life, we are there to support them, but they are expert in their life. So participative approach is important. Then uphold and promote human dignity and well-being. So that is a basic value of social work. Respect for the right of self-determination. If people have the choice and control, if a particular person say they don't want to have service from us, it is their kind of decision regarding that. Okay, so promote the right of participation. For example, based on people have a particular diagnosis, dementia or learning disability, we cannot discriminate people and take decision for them. As a social worker, it is really important to ensure that we need to include their participation. If we are not evidencing in our assessment and support plan their participation and engagement, we might be acting against the law. So we might need to adopt different communication methods and techniques to encourage their maximum participation in decision making. Work holistically. Holistic approach is important. Partnership working with many other agencies. Different agencies have different shared goals and interests. It is important to understand about different agencies working, and clear communication is important. Identify and develop strength. Okay, so it is important to identify people's strengths rather than their needs. Okay, and another important value based approach in current situation is prevention, because local authority, previously known as supporting people when they are in crisis, and that given much burden to local authority and also people facing crisis, which wouldn't lead to recovery. So currently there is a massive campaign for the prevention, which is under Care Act 2014. So as a social worker also, they will be asking how we can work according to Care Act section 2, where we can support people to have prevention of care needs and reducing and delaying of developing further care needs. For example, what are the reablement support we can put it in place for people before they come to crisis. And also, when we are working value based approach, we are working according to so many social work theories, which you need to really familiar as well. Okay, when we are attending interviews or when we are working in social care, we need to understand that our work is based on social work theories. Otherwise we end up working on assumption basis. Most of the time our assumption and judgment may not be right. That's why we need to cross check when we are taking decision. Are we taking decision based on a particular social work theory, that is information based decision, and also are we referring back to legislation? So there are many theories. So some of the theories I could mention, you might need to familiar with social learning theory, where how people develop and understand their behavior in a social context, how they are adapting and changing their behavior in according to social learning. Another important approach you need to learn is strength based approach. That is a really relevant approach in social care. So you need to really learn and read about social strength based approach, where you need to identify people's strength rather than being a deficit approach. And also person centered approach, that is a basic approach every professionals use when we work with people. You might need to be familiar with empowerment theory. Example, when you are working with people with a disability or people with a victim of domestic abuse. And also you need to familiar with system theory, how each system work around people, and when a particular system fail, how this impact people's well-being. And also you might need to get familiar with Thompson's model of PCS analysis. That is really interesting and important model of theory, which would explain how oppression works in society. For example, PCS means oppression we face in personal level, we face in cultural level and structural level. Okay, so this session may not be enough to explain this theory, but take a note of these theories and try to read and research about this theory. A very whichever theory you are reading, there are interesting website and which would explain it simply. That website is called as SEIE, Social Care Institute for Excellence. So that is a really good website if you want to read and research about social work theories. Okay, then when nowadays when you are getting interviews and when you're working in social care, uh, there are changing in culture. As I said before, uh, people being overly depending on social care. Okay, because the UK state is known as a welfare state, because UK, every local authority has responsibility for people's well-being. So actually, people being overly depending upon people's own state. Okay, so in current situation there is a funding crisis. We haven't got enough resources to support all the people who need support. People are experiencing loneliness, and also people lack support within the community as well. So there is a shift in culture within the local authority, where they are promoting to work with people, encouraging to integrate people within the community, and closely working with the family. And there are so many charity organization, voluntary organization work in each local authority. So now they are encouraging social workers to explore those support provision within the local authority, so that they are not completely depends upon care package or care homes. Okay, so before that there been a culture, we've been deficit oriented. We say that people have a problem, people have a need, people have a weakness, we need to support. So now there is a cultural shift. We think people are expert in their life. Instead of we doing things for people, we need to work with people. That is a power dynamics as well, because that negotiated the power dynamics. And we are identifying people have strength rather than weakness, and rather than we see people as a problem, we people as a person. Okay, whenever you are writing a personal statement, as completing assessment or putting personal statement for interviews, you need to remember that you are not supposed to focus on problems. Okay, please don't identify you are dealing with people, or you are kind of trying to solve the problem. Actually we are not there to solve the problem. Okay, so that is a medical approach where we only see the problem. Social workers are working on a social care approach, social model. Okay, that is based on we are seeing the person rather than the problem. Problem is something there. Okay, that people can address with our support. Okay, so first we need to work with the person. So we need to see the person before seeing the problem. So we need to be mindful of the terminologies we use. Okay, So that is basically about adult social service and how they function. So if you ask me, when we say care and support needs and the support provision in UK, support provision comes in different aspects. Okay, as I said before, it can come in a domiciliary care aspects where people live in their own home, where care package will be put in place. For example, a carer will come in the morning and evening or in the lunchtime to support with personal care and cooking, uh, having a wash or tidying up the home. So that is known as domiciliary care or care package. Then there is other support when people are unable to, for example, a younger person, 25-year-old with a learning disability, they're unable to live safely in a home environment. They might need to live in a supported living environment or supported accommodation where there will be a person who will be 24/7 there to support them. There might be other people living in the home as well, 2 or 3. Okay, so that is not a supported living or supported accommodation. There is other provision called care homes, that can be residential care home or nursing care home based on people's need. Okay, and also there are other service provisions called shared living, and there are other kind of reablement provisions, short-term and long-term provisions are there. Okay, there are some psychiatric settings and mental health settings as well. So that is how social service work and provide care for people. Every time whenever social service is doing assessment, they are responsible to review on regular basis as well. Okay, so that is the holistic picture of adult social care. And I know that time is moving and there are expertise waiting to explaining you how each team function. So thank you.
Thank you, Susan. Now I kindly request Mr. Martin Chaku to do the presentation for the adult social care team, the roles and responsibilities of social work under the CARE Act 2014. Thank you.
Good morning, everybody. This is Martin. I believe Susan has already covered some of the areas which relates to the... Can you hear me?
ഒരു മിനിറ്റ്, സൂസൻ ഒന്ന് സ്ക്രീൻ ഒന്ന് ഡിസേബിൾ ചെയ്യാമോ? ഓക്കെ,
സോറി ട്ടോ, ഞാൻ
നിങ്ങൾക്ക് വേണമെങ്കിൽ സ്ക്രീൻ ഷെയർ ചെയ്യണമെന്നുണ്ടെങ്കിൽ ചെയ്യാം.
That's okay. That's okay. I don't have a PowerPoint slide to share, but I would suggest, okay, if anybody looking for fresh information or want to rewind your information, okay, please feel free to take notes. But I'll be happy to put something together later if you wish to have them together. Excuse me. Yes, in terms of the adult locality teams functions, I'm sure Susan has already covered some of the areas. Maybe the case I will try to focus on the one or two of the main functions of the adult locality teams in the UK. As we talk about the adult locality team functions, I think it is very important that we have an awareness of the 6 key principles of the CARE Act 2014, which are empowerment, protection, prevention, proportionality, partnership, and accountability. So this actually puts or promotes the person-centered approach in our involvement. It also promotes well-being of the vulnerable adults. And these are the 2 key functions we actually try to achieve through our involvement with working with the people in the community. And when we go back to the key functions of a locality team or adult care team, I think one is care need assessment or reviews, as well as mental capacity assessment, facilitating best interest decision making, protection of the vulnerable adults, which is safeguarding interventions. So these are some of the key functions. And let us go back to the assessment. Okay, what do we need by the assessment in the CARE Act? Assessment is an assessment of the needs of care and support, or assessment of the needs of a carer, if they have got care needs. Okay, and the nature of assessment will vary depending on the different circumstances. However, all the assessment we complete needs to be appropriate and it should be proportionate in terms of our involvement as to how much effort do we need to put in for completing an assessment and what we try to achieve in terms of putting together an assessment in action. And we complete an assessment, care need assessment, and some of them may need reassessment depending on the outcome of the review of the package of care we may have put in the initial stage. This actually comes together as a one part of the process in terms of assessment as well as reassessment, which is the outcome of the review of the package of care. Now, who can have an assessment? Okay, in terms of the adult, any adult who is above the age of 18 is entitled for a care assessment if they appear to have some care and support needs. If it is very clear that that person do not have or do not appear to have any eligible needs, there is no legislative requirement in order to actually complete, which again means the focus is if there is an appearance of care and support needs for the person. Okay, now next question. Okay, there is something like threshold as well as self-fund days. What does it mean? Okay, when it is a threshold, okay, in terms of the care act requirements, okay, any person who may have finances, money, in terms of about 23,250, in terms of the liquid money, shares, investments, bond, whatever form of money they hold. If they have more than 23,250 in their finances, whatever be the care needs of that person, they are actually expected to pay the full cost of care for their needs, even if it is organized, commissioned by the local authority. If their finances is below 23,250, and then there needs to have a financial assessment to determine what is the level of their contribution. So what I try to say is, there is no free care and support that is provided by a local authority as per the Care Act. Okay, it is all mean tested, depending on the affordability of the person. And that is why what is decided by the financial assessment. Okay, now, what if somebody actually does not want to have an assessment? Well, individual has a right to actually decline or refuse a care assessment. However, if they have the capacity to do so. However, if the individual lacks capacity, then a decision about the appropriateness of having a care assessment needs to be based on the mental capacity areas, which means if the person lacks capacity, then we need to take a best interest decision in order to make sure a care assessment take place. Okay, or if there is an identified risk level to the person or to others, even if the person actually refuses care assessment, we need to actively consider a care assessment if that person actions actually is a risk to himself or to others. Now, what should actually be on the record of a care assessment? I think it is important to have the full individual needs as well as their views and wishes needs to be actually established in the care assessment. The assessment record also needs to actually hold assessors' views in the individual's outcomes in terms of what they would like to achieve. Okay, consideration needs to be given to the person's views, as well as it needs to be strength-based in terms of the approach. The consideration needs to be given to informal carers or their network who may have contributed to the assessment process. And again, we should be able to give advice to the issues we may have discussed in the assessment process. We also need to actually include a professional analysis of the matters we discussed, as well as what may be the potential options in order to try to resolve or to make progress or to promote independence of the person. So what are the key principles of the care assessment? Okay, it needs to be strength-based, it needs to be transparent, it needs to be family, we need to complete a family approach, or it needs to be holistic. It should actually try to maximize the person's involvement. We should recognize the fluctuating needs in the assessment and promote individual choice as well as control. It also needs to be proportionate. Now, how do we actually assess, or how do we decide if somebody actually meets character eligibility for care and support from a local authority? I think there are three key questions which we need to undergo. One is, do the needs arise from a physical or mental impairment or illness? If answer to the question is yes, we move to the next stage. Okay, do any of these needs means the person is unable to actually achieve any of the 10 outcomes actually specified at the care act? If the answer is yes, we continue. Does it have a significant impact on the well-being of the person? So we have three questions. If the answer to three questions are yes, certainly this person meets criteria for the eligibility or in terms of the care act. So you may wonder, okay, how to actually do a care assessment. I believe, okay, I don't know what's the recent developments in Kerala or India in terms of assessing situations. But as far as I am concerned, I think for me, what helped in my first job in the UK was my placement in one of the psychiatric hospitals back in Coimbatore in 1996, which means, okay, I think back at home, you may call it as a case study, where you actually try to establish all the details of the person, their difficulties, and whatever plan they may have. And in terms of the care assessment, there is no specific way to actually complete the care assessment. It depends on person to person. There is no specific styles to actually complete the care assessment. It depends on your creativity as to how you want to play the ground. Okay, now, you may actually start with somebody actually talking to with regard to the health issues. You may start talking with regard to how they manage at home. You may include, okay, how do they manage their medication? Are they able to get in and out of bed independently? Can they mobilize independently? Are there any adaptations, or are there any aids to support them? Again, okay, do they feel isolated? How are they able to manage their meals preparations? Do they have any friends, relatives visiting? How do they manage the finances? Is there a power of attorney setup? Or if there is no power of attorney setup, okay, whether there is any other provisions where somebody is actually informally actually supporting them. These are some of the areas we may have to actually consider in order while we actually complete the care assessment. Again, some of the other key areas that needs to be considered is, okay, if somebody actually meets criteria for character eligibility, I think it is important we actually discuss the charging policy of the council. As I said in the beginning, okay, there is no free service provided by the local authority in terms of care act bound care support system. So they need to be actually aware of the implications of the finances and what maybe they may be able to actually contribute. We may also actually explore technology-enabled care. Even if somebody actually meets criteria for care and support from the local authority, that does not mean local authority have a duty to actually provide care and support, if there are other means and ways to actually meet those persons' needs, which can be family members, relatives, neighbors, non-governmental organizations, charitable organizations, etc., voluntary agencies. Okay, now there may be certain devices which can actually, or technical means which can actually support people to actually maintain their independence or to promote their independence, or make them support them to actually enhance their choice in terms of decision making or to ensure their safety. And it is for us as professionals to actually explore those options instead of actually putting other active service provisions in place. It may be the case, we may also have to actually consider continuing healthcare, just to check if there are any superseding health needs than the social care needs. Which means we may have to actually consider continuing healthcare checklist in order to actually understand, establish whether the needs can be met through or by funding from by the health. We also need to actually actively involved with the Mental Capacity Act. Basically, we are trying to say, okay, every person is supposed to have mental capacity unless and otherwise it is proved so. So if you have any concerns about that person's capacity, we need to clearly complete a mental capacity assessment. And what are we looking at it? Okay, the person actually able to understand the information? Are they able to weigh up the information? Are they able to make a decision? Are they able to actually convey the decision? Okay, if you have any concerns, if the answer to the questions are no, then the person lacks capacity. So what is the outcome? We need to actually complete investment into decision making. And the person who actually facilitate or complete the mental capacity assessment should be able to promote and help the person to actually make the decision. And any decision taken in terms of the mental capacity assessment should be least restrictive to the person. So our aim is to actually promote independence, try to enhance the independence, or to have a strength-based practice. And also we need to have the practice which is evidence-based. We should be able to make a decision as to and explain as to why I take a particular decision at a particular time. And that is one of the fundamental requirements of a profession. One of the other areas we need to actually consider in the care assessment is risk enablement plan. We are not risk averse. We cannot actually say, because of this and this risk, we need to put some certain things. We should be able to actually put forward a plan in order to actually enable them to take some risk in a comfortable, safe manner. And again, these few things will actually enable us in order to actually promote the independence of the people. And again, when we go for a care assessment, okay, we also need to actually, if there is a carer involved, we also need to actually offer a care assessment to a person, which means there may be a family member or a neighbor or another person who may be spending substantial level of time, in order to support the person or the service user. In those situations, we need to actually offer a care assessment. Again, they can actually decline a care assessment or they can accept it. So it may be the case, some of the local authority may be actually outsourcing this service. So if that is the case, we need to actually make a referral in order to actually complete a care assessment to make sure they are supported to continue with their caring role of the person. Now, what happens if somebody finances is above threshold? We told, okay, the person will be expected to pay the full cost. Does that mean, okay, the local authority needs to actually commission the care? It is not a necessity for the local authority to actually commission the care directly if they are able to source it privately with support. If they've been, okay, if we say, okay, with support, there are many local authorities in England who actually have different, brokerage team who may be able to actually help the service users to actually purchase or commission care privately, set up the care privately, which means as long as the person have capacity, or if there is a person who has somebody to liaise effectively with the brokerage team in order to actually purchase care privately, then that is a possibility. It does not mean local authority has to actually commission the care for the self-funders or people who are above the threshold. I think Susan has already clearly mentioned above in terms of what type of care or support we may be usually putting in place. As Susan rightly explained, okay, it may be home care, it may be respite care, it may be day care, it may be residential care, it may be short-term care, it may be long-term care. Yeah, again, there may be different categories of care in terms of placement, okay, whether it is older persons, whether it is dementia related care, or whether it is mental health care, or it is LD, learning disability related care. So different types of care also there. Again, one of the key area, just at the upfront, we should be able to establish just at the beginning of the process, whether this person actually agrees to have an assessment, whether we are getting the consent to have an assessment. I think these are some of the key areas in terms of functions of the social worker. One of the other areas is safeguarding. I think, yes, we have another session specifically for safeguarding, so I'm not going to touch there. But in terms of the main teams, locality teams, adult locality teams functions, okay, it is care assessment, it is reviews. Suppose we put in a package of care, whatever it may be, placement, home care, day care, respite, whatever it is. Okay, we need to actually periodically review the package of care. And if there is any change in the needs, yes, then we need to a reassessment in order to actually incorporate that change in need. So we may have to either decrease the package of care, or we may have to actually increase the package of care. That's all relating to how effective the plan is going to be. There can also be a reablement service in order to actually promote the independence of the person. We, in some circumstances, okay, we will actually try to, we'll be very clear in our assessment that this person has a potential to improve and that person will not need any hands-on care. So that is where we can actually explore reablement service, which is 3 for up to a maximum of 6 weeks. It is not 6 weeks, but maximum of 6 weeks, where the person can have input or support from therapists in order to improve or to promote their independence. And again, at the end of the reablement service, there'll be a review which will establish if the person needs to have long-term involvement or care support system in place. I think these are some of the basic of the care assessment, as well as some of the functions the locality teams in the adult care have in the UK. So if you have any questions, I'm happy to answer, or we will move to the next one, depending on that time.
Thank you, Martin. Next, we move on to the next section, which will be conducted by Dr. Shibu Velatepalli. I think he's having some issues in regard to his connections today. He mainly presenting about the adult safeguarding and concept and process of the social worker. Let me introduce Mr. Shibu Velatepalli.
Sheena, I think we lost him again.
I think we can proceed to Mr. Thomas next. If Shibu is not there, don't waste time.
Yeah. Okay. So what we'll do is, because as you all know, that there is some issues around his connection, because he's not in his home. He's out on visit, so probably that's maybe causing it. So we'll try and keep it possible. So if he comes back, we can rejoin him at any time. So from now on, what we heard was predominantly about the structure of adult social care in the UK and how that is being framed and structured around providing and supporting people with care and support needs. So we heard about the adult social care team, which is very well established in the UK, and to support other people who may come across having care and support needs. The local authorities in connection with NHS England, in connection with other third-party system partners, developed a specialist team to support. So we thought it may be worthwhile to have a kind of brief introduction to those teams as well, so that those who are looking for jobs or those who are looking for additional information, that may be beneficial to you. So we have got a very clear structure. So we have got a hospital discharge team. We have got specialist teams in mental health, learning disabilities, and physical disabilities. And in these teams, so they do have a slightly differing practice areas and practice procedures. So to introduce the hospital discharge team, I invite Mr. Thomas Joseph, who is also the chair of our forum, who is a deputy manager within the services. So to give a brief overview of the hospital discharge teams in the UK.
Hello, everyone. Can you hear me? Yeah?
Yeah, yes.
Okay,
yes.
I'll try if I can share my slides as well. Right. Can you see the slides now?
Yes, we can.
Okay. Right. I think Susan has touched upon some of the aspects of the hospital team as well. However, I'm trying to give a little bit more in-depth into hospital social care and hospital working in the UK. So that can then, if anybody, as Viju rightly said, in future are looking for jobs, you need to be very clear that in UK, adult social care is a very broad field. Social care is a broad field with children and adults. And again, adults has got different spectrums where you can work on. And Susan did show you different types of the teams and all. And one of the focus areas of the social care in UK is predominantly is hospital social work. Fortunately or unfortunately, I was working in the hospital social care since almost throughout my career since I was in the UK, but sometimes dipping in and out, going into the community teams. So the purpose of the hospital social care in UK is to ensure a timely and safe discharge of patients who are in the hospital in acute and community hospitals. If you know the hospital structure in UK NHS, you predominantly have the acute hospitals, which is like, with the hospitals with the A&E, different wards where the active treatment is given to the patient. And the community hospitals also, they call it sometimes as the rehab hospitals or, recovery hospitals. So these two are the two types of hospitals mainly that NHS works in. So we work in both in the acute hospitals and also in the community hospitals. Sometimes some of the community hospitals these days, they also use some of the care homes. They have both beds in care homes and they use it as for part of the community hospital for the recovery. So these are the areas where social services we are working actually. So, and the purpose is to ensure a timely and safe discharge. I think these two words are very key in the hospital discharges: timely discharge and a safe discharge. Now, going to the role of a social worker in a hospital team, a hospital social worker phenomenally helps people, to get discharged, as I said before, in a timely and safe manner to a safe place where they can be supported. And the safe place can be, again, their own home. And the primary focus will be a discharge back to their own home or their own environment and the recovery there. But there may be cases where sometimes people can't be discharged back to their own home. Then they may go into a care home or a nursing home. Again, usually if they are going discharged from a hospital first time into a care home, it will be for a short period of time. And then further assessments will be happening there. And then they will be followed up, and then a decision would be made whether they go back to their own home with care or without care, or they go into a long-term care into a nursing home or not. So that is what the usual discharge process and where the social workers are involved. And in case some of them may be not needing any formal support, then they may be needing some advice and guidance or needs to be redirected for support in different places, and then that will be happening. And the type of support that we provide from the hospital, obviously, Martin did mention about the enablement, and different people call it different names in different counties. Some call it enablement, some call it recovery, some call it reablement. So that would be the primary focus within their own home or in a rehab setting, or could be in a discharge to assess bed, they call it. Now, coming to the legislative framework that governs or guides the discharges are predominantly, of course, all the legislative framework in social care in UK are applicable to the discharge process or discharge from the hospital, including mental capacity, safeguarding, care act, human rights, and everything is applicable. But I'm just, for the purpose of today, mainly just focusing on the main legislative framework that is being used when we work in the hospital setting. That is, previously, when I joined the social services in UK, or until a few years before, the main legislative piece that we used to be working in social care in the hospital was the Community Care Delayed Discharges Act of 2003. And as per that, we used to be getting, because the reason I'm mentioning this, you may still be hearing about it, although we have moved on from there, but you'll still be hearing about it. So it's good to know about it. we used to call something called a Section 2 and Section 5. Section 2 is the primary notification that a hospital provides to social services to say there is a person admitted to the hospital. That person may be coming across your way and may be needing your assessment and support. And they used to be able to give a minimum of 72 hours to social services once that notice has been issued to social services. And then we get another social notification that we used to call it as a Section 5 notification, which means they are going to tell us, the hospital is telling us, the person is now fully ready to leave the hospital and they are here only waiting for social services input, social service assessment and discharge from the hospital. And we used to be getting 48 hours of time. By then, a person needs to be discharged from the hospital safely. And if we don't, then it will be the responsibility, exclusively the responsibility of the social services for that person being in the hospital. Any delay from there is a responsibility of social services. So the discharge was the exclusive responsibility of social services, of course, working with others, but there it is a statutory responsibility of the local authority to ensure the discharge of the person. There used to be a delay charge for the delayed discharge, for example, after the issuing of the Section 5, after 48 hours, and if the person is still in the hospital bed per day, the social services are to pay a fine to the hospital. It was £100, I believe, if I remember correctly, it is no more there. And every week, we used to be having a meeting in order to discuss whose delay is this person being in the hospital and how many days of delay for the social services, how many days of delay because of health issues, and then the number of days that social services delay, they will calculate and that charges will be sent to the local authority, so they pay to the NHS. So that's how it used to be managed. Now, those times have gone. I do still dreaded those days actually when we used to be going to discuss with the managers, senior managers from NHS to confirm that it is social services, because social service managers will be asking why there was a delay from social services, because they have to pay for it. And therefore used to be a very, kind of the relationship sometimes was not very good as well, because of these arguments each other. Those times have gone. Now, the guiding principles of delay for the discharges from the hospital is Care Act 2014 broadly, because when I say broadly, because again, there has been change in 2022, which I will be mentioning later on. So since then, now the process is there is a single referral form. Because if I mentioned previously, there was a Section 2 and Section 5. That means they used to be giving us 72 hours of notice after Section 2, 48 hours of after Section 5. We had more time. Now that is gone. We are given a notice, one single notice, and once you receive that notice, all that is just a basic information about the person, you have got 24 hours to get that person discharged from the hospital. If not, there is no charge again now as previously, but there is daily meetings that is happening. So sometimes it can be once a day, sometimes it can be twice, sometimes if the hospital is on alert, it can be even more times, where the managers come together and discuss and fix the issue why the person is still in the hospital. And then everyone has to make a responsibility to get that person discharged. Now it has become a joint responsibility of health and social services. Previously, under the Delayed Discharges Act, it was exclusively the responsibility of the social services to ensure the discharge of the person. But now it has become a joint responsibility, because health can't wash their hands and say, no, it is no more our responsibility as a social service. No, it is a joint responsibility. And there is no more delayed discharges charges as well nowadays. Now, the next slide, I'm going to speak about a few advantages and disadvantages or challenges of working in the hospital social care. Again, I'm speaking about this so that when you make a decision about your career in social care in UK, in adult, you can make a decision based on knowing, is this the best one for me, or is it not the best one for me. Which one should be I be choosing, in order to work or in order to progress my own career. So the advantages are you have a very limited caseload because you don't hold the cases. Therefore, the cases you work on, as soon as the person is discharged from the hospital, is going into a community team. As Martin was telling, where Martin and are working, the community teams, the cases are being transferred to the community teams. Therefore, you don't hold the cases, because as long as you don't hold the cases, any concerns or any issues, you don't have to deal with those cases, because that is gone to the community team and they deal with it. You just do a very light touch assessment. They call it light touch assessment, so that enough information gathered in order to ensure a safe and timely discharge for the person. You don't do in-depth assessments. Again, that will be a challenge. So you have got the opportunity to do working with MDT, multi-professionals like physios, nurses, healthcare, different other healthcare professionals, the consultants, doctors, everyone in the hospital. You work together with them as an MDT, because it's all everyone's responsibility to ensure a safe discharge of the person. So I said it's a health and social care responsibility, not just the social care alone. So you get that opportunity to work together. So you don't have to keep holding long-term cases. You don't keep any complex cases with you, because all the complexity of the cases along with it, as long as we ensure that the person is safe enough to be discharged, we discharge the person. And anything after that, all the issues related to that case or the discharges, then that goes to the community team and they carry on with the work. Again, safeguarding also, we do very limited work in the safeguarding. That's again into, I'm sure you will be hearing about it from the next speaker. So we only deal with the safeguarding, that is to ensure that the person is safe enough to go. So those are some of the advantages. Now coming to the challenges, because you don't do in-depth work in social care work, you might start maybe sometimes losing some of your in-depth social work skills for the assessment and care planning, because you are not doing that over the period of time. Then you have working medical versus social model, because the health professionals who are working, they have got in their mind set up a medical model of work. And you're going there with a social model where you're trying to make the person independent. You're talking about always about independence enablement. But on the medical model, that is not what they are risk averse, more. They always talk, oh, that person is risk, that person can't go home because there is a risk of falls. But on the other hand, on a social model, you'll be speaking about yes, people should be taking positive risk. And if that's what they want, and they should be going home, if that's their wish, and they should be becoming independent. So then there will be some issues about shifting responsibilities, because the medical model, they will say, well, it is your responsibility if something happens to that person, then if he goes home. So those medical versus social model conflict is going to continue. That's going to happen. Then, of course, you will always be challenges from the health colleagues, as I said about the medical model, because they have that understanding. They'll be speaking about that, and then you'll be speaking about on the social model. Then the greatest pressure that working in the hospital team is a timely discharge, because you're working with the different partners, different limited or sometimes limited resources. You always have the pressure that this person cannot be in the hospital bed as soon as he's been medically declared as medically fit for discharge, not because of anything else, because the hospital bed is very premium in the NHS. All those who are in UK will know how difficult it is to find a bed. Sometimes people are in the corridors waiting for a hospital bed. They're in the corridors, just, in the, what you call the trolleys, lying there for days because there are no beds in the wards, because the people are still, some of the people who are medically fit are still not gone. They are still there. Now, there will be family pressure, especially for getting person into a residential nursing home, because they use this as an opportunity. When the people are in the hospital, they know if they put the pressure, they may be able to heed. And when you go and speak to this person, he say, no, I want to go home. But then the family, on the other hand, telling you, no, this person can't go home. They will be going into a nursing home. And if anything goes wrong, you are responsible. So those kind of pressures are there in the hospital work. You will have to deal with it, which is, I'm not saying there is no pressure in the community work. There's plenty of pressure, I am sure, especially when it comes to safeguarding work and all. But then, that's a slightly different pressure. Now, the advantage again, when I say is sometimes the hospital teams get a little slightly higher pay because of the difficulty to find social workers and to keep social workers. They sometimes get an additional benefit, or what you call a market value, they call it sometimes, to keep the person. So that is one of the advantage working in the hospital team. Then most hospital work, you don't have to travel. Your travel is, if your office is based in a hospital, where when you need to get to the hospital, that's your travel. Once you're in that hospital, you see everyone in the hospital, and therefore you don't have any travel outside your hospital work when you're in a hospital team. Then one of the biggest advantage when compared to the community team is resource availability. Because it's a hospital discharge, there is a pressure from NHS and from everybody. That person needs to be out of the hospital. It is slightly easier to get, the resources available and to getting agreement for packages of care and things. And there is also a lot of free care, like enablement, which is health funded. So there is a lot more resource in order to get a person out of the hospital when compared to, in the community, where you have got the resources are very much means tested, which means like based on your finances. Somebody was telling, Martin was telling about if you got anything more than 23,200, 300, 250, including, for example, if you are living in a property, and if you got another property, now they take even the value of that property into account, even to provide domiciliary care. So those things are not coming into the picture, most likely don't come to the picture when you are working the hospital team. Then continuing with the challenges, then, you can slowly become adverse to positive risk taking, because you try to get the person, there is resources, just get them out. Then hospital social work is ever dynamic, keep changing. Because when we used to start, we used to, do the assessments, we used to be discharged. And now it is changing. There's a lot of big changes happening, especially since the COVID period. Now there is a discharge to assess process, where many hospitals, social workers are not doing discharges. The discharge is given as a responsibility of the health. You discharge the person from the hospital, and then we take the person, or we see the person in the community. So that's massively happening. In some counties, it is local authorities already fully established. In some local authorities, it's kind of a mixture happening. And therefore, some social workers may be in the hospital, some hybrid working, some there is no hospital social workers at all. They are all separate outside hospital teams, but seeing the people in the community. So that discharge to assess process is very much in the making. Actually, it is happening in many local authorities at different forms now. Now, the one of the key things I was talking about, the Care Act, and there is some amendment to the Care Act that has happened with the Section 91 of the Health and Care Act in 2022, kind of given some leeway for social services and local authority under the Care Act 2014, that social services no longer is mandate. There is no mandatory rule for social services to carry out assessments in the hospital. That's why I'm talking about the discharge to assess process, where the health is taking the lead now for the discharges mostly, but still it is very much work in progress. So I personally foresee there could be a big shift, big change in the hospital social work in the future. And it could be that all the hospital initial discharges may go to health, and social workers may be employed by the health for if they need help with the discharges. It may not be local authority doing it. Now, the structure is similar with any social work teams. Hospital social work also usually in different, again, local authorities, they call it in different names. Head of service or director would be kind of a top person. And then you have the deputy head or a service manager level. Then you have every team will have a team manager and then a deputy team manager in most cases. Then you have a senior social worker or an advanced practitioner level. Then you have got social workers, ASYs, the new social workers, and then support worker or a community care officer and business support team to support overall. So it can be slightly different local authorities. That's why I put different / names actually. Right, and I think that's the end of my presentation. Thank you very much, and over to you, back to you, Biju and Sheena.
Hello, hi, thank you, Sansita. That was wonderful. Really appreciated. I'm looking at the time slots now. I'm just looking at. We've got half an hour to run. So I was thinking that we might slightly change the structure of the session today because we've got Shibu here. Shibu, are you able to do it and then we call it a day?
Yeah, I am here, Biju.
Yeah. Okay. Yeah, we'll try. Because
can you just make me
screen share, please? Yeah. Okay. Now, so there's a possibility that because we may have to after your session call it a day because it's already nearly 1.5 to 2 hours now. So we'll have some time for the question and session at the end. Yeah, and the mental health and other specialist service teams will do it another day if everyone is okay with that. What do you all think?
Yes, that's fine.
Biju?
Yeah.
Hello?
Yeah.
Hello, Biju?
Yeah, Shibu.
Hello?
Yeah.
Biju?
Yes, I can hear you. Yeah.
I think that if it is difficult, we can arrange another session specifically for safeguarding. I'm quite happy to do that. Hello?
Hello. Yeah, I can hear you.
Biju, if it is necessary, we can do it another session specifically for safeguarding. I'm quite happy.
Okay.
That may be a good idea actually, because safeguarding in itself can be a full session actually.
Exactly, because you will be needing more time to discuss about the question and answer session, which needs to be cleared today. Because if you postpone it, the people will be forgetting about that. I think isn't it?
Yeah. So what we can do then? Yeah. Okay. Thank you very much for that. Then what we'll do is that we will just cover the mental health as well, and then get it out of our way. Yeah. Is that okay then? So that means the specialist team is completely over. Yeah. Okay, that's good. Thank you. So the next team that we're going to talk about is the mental health services. So as you know, again, the mental health services, there's another area of practice for social workers. I'm proud that when I came to this country, I started as a mental health social worker. So I never knew anything about it. So I started as a social worker there. So and I was very anxious and worried and very much apprehensive about my role. But all these years, last 18, 19 years, it's proved to be a good move. So but the problem is sometimes when you start in these new roles, it can be slightly overwhelming and challenging. So I'm just going to give me 1 second. I'm just going to share my screen if don't mind. Okay, so can you see my screen now? No.
Not yet. Yeah.
Yeah, it's coming.
Yes.
Okay. Yeah. So there is this, what I'm going to cover today is what is mental health social work, what means mental health in social work and mental health, and what are the responsibilities, roles and responsibilities of qualified social workers in it. So the objective of the session is to create an awareness of the social work perspective within adult mental health services, Again, we have got two different services. We have got CAMS, which is under 18s, and over 18s is called adults. So that's why I put adult mental health and the responsibilities of a qualified social worker within these groups. And to discuss different teams and roles undertaken by qualified social workers within these services. So you can look at, when you look at job interviews or job advertisement and things, you'll be slightly aware of what that means, so that's the reasons why I'm presenting this. So why social work in mental health? So that's always a challenging question when somebody's been asked why a social worker in a mental health team. As you know, in modern medicine, mental health is predominantly looked at as a kind of biopsychosocial perspective. So there is a biological perspective to mental health, there are social perspective to mental health, there are psychological perspectives to mental health. So as a part of a social worker, it's our responsibility to bring that social perspective to the care of patients with mental health issues. So it offers, to understand, based on those understanding, these days, we have got an integrated health and social care approach to care, which is predominantly arranged under Section 75 Agreement of the Health and Social Care Act. Given that some of the local authorities have decided not to be part of that agreement as well. So where I work currently, we are not part of that agreement. So we do currently have a different independent approach to it. But most of the local authorities and NHS bodies, they work together to provide that care. And secondly, there is a responsibility, local authority responsible for providing care to people under different legal legislations, legislative frameworks such as the Care Act, irrespective of where they're coming from. If the person has got a care and support need, that should be delivered. So one of the key areas or areas of disability within a UK population is mental health. So there is a need that social workers should be there, employed there to promote that social care assessment and support and protect and safeguard patients. And thirdly, there is a responsibility under the Mental Health Act and Mental Capacity Act and the provision of liberty safeguards that local authority has to deliver certain responsibilities. So these are most of the time reassigned to a social worker, which is sometimes called approved mental health professional or best interest assessor roles, which Mr. CP Sebastian is going to cover briefly because that's a specialist area of practice as well. So that's the reason why social workers are employed in mental health services. So what is the responsibilities of a mental health social worker? I'm not going to go in detail because, as I said, is to provide a social care assessment and delivery of appropriate care and support, to review packages of care, as mentioned in earlier presentations, to offer, a social perspective or social system-based support, so that to manage their social factors, to find solution to their problem, and to support them to live independently, because these people are, along with their disability, living in a society where they are facing key challenges. So they need to be supported from a social perspective to live or lead a healthy life or live an independent life, and again to protect them from any harm or abuse, because of the vulnerability, they are prone to have, prone to victims of abuse or the harm. So that should be safeguarded. So also to undertake mental health assessments and offer support, because sometimes we think, social workers in mental health teams also have to undertake mental health assessments, not just social care assessments. So based on which team you're working, you have to have that specialist interest or specialist skills and knowledge to undertake mental health act assessment and manage their mental health and well-being in the community. And again, legal responsibilities. As I said, mentioned before, there are some legal responsibilities for a social worker. And again, assess a patient's mental health and risk in the community. Okay, so to provide that, there are different teams and structures within the UK. So I would say there are key teams. There are some specialist teams, but there are key teams that you might have come across as community mental health team and early intervention teams. The community mental health team is for people with the complex mental health needs and who need ongoing care and support and monitoring. So social workers are employed as care coordinators, not just as a social workers, but as a care coordinator. So that what that means is they coordinate the care of that particular individual, whether it's a medical care, whether it's a psychiatric care, whether it's a social care, whether it's psychological care, whatever it is. These social workers or care coordinators are. They can be care coordinators can be from any profession. They can be occupational therapists, they can be nurses, they can be social workers. Whoever they are, they have to do that generic role, not just a role that's specific to their profession, but a generic role of a care coordinator. Okay, so that's the key changes that you will notice. There is another team called all adult CMSTs, predominantly people, I would say that in one of the teams that still able to manage some social work practice is the adult social care teams, because they purely their focus is on doing the assessment, social care assessment and support, and reviewing packages and care, and there is limited source for kind of mental health related work. So one of the key area changes is predominantly these adult social care teams are sitting within a local authority framework, and they undertake work for local authorities. There's another called EDT and ARM hubs. So I'm sure the CP Sebastian is going to speak about those, so I'm not going to go in detail. But these teams are developed to deliver local authority responsibilities under the mental health and mental capacity and the other legal frameworks. We've got a home-based treatment team or crisis services, which is again very specialist health-oriented teams. And the role of a social worker is more of a mental health practitioner than a social worker. So you need to have extra skills and knowledge associated with mental health to be able to deliver this role. Given that, when I started these roles, I never had any mental health experience. So I learned, and, it's easily, you can acquire these skills easily within, and you'll get all the support and training. So, but it's predominantly a mental health practitioner role. So its practitioner role is different to social work role. So you need to be aware of that. Then you have got specialist teams like the primary care services, joint response team, single point of access team. Well, all these teams are purely clinical assessment and support teams, not social work, social care assessment and support, but it's clinical assessment and support. That what I mean is, as I said before, your role is more of a practitioner, mental health practitioner, not as a social worker. So you need to be very clear in this thing. So that's why when you apply for certain roles, it's good to have this understanding and then talk to people who work in the areas to understand how they do their work, what are their daily routines, what kind of things they do in their practice. So that will help you to apply for jobs better, present in the interview well, so and in an informed way. Yeah. So the last but not least, the roles, different role for social workers. As I said before, you've got a qualified social worker role. So we've got, that's purely to offer social perspective and care to people. Predominantly, these roles are only available at the moment in adult social care teams, because all adult social care teams, because the need for other interventions. Care coordinator roles, purely CMSTs, EITs and things, they provide care coordinator roles, which is open to social workers, nurses and occupational therapists. So if you're a qualified social worker, you can apply for these roles. AMP and BIA training. So once you're a qualified social worker and had a bit of a practice in mental health, you can be trained further to become an AMP and best interest assessor. I think CP Sebastian is going to touch on that, so I'm not going to go in detail. Then you've got clinical roles. Clinical roles, again, as I said, you can apply for mental health practitioner roles or clinical lead roles or senior practitioner roles or advanced practitioner roles. But again, with purely on your social work experience, you can't do that. You need to have a bit more mental health expertise as well. And knowledge and skills around mental health assessment and treatment and support. So once if you got that, you can apply for clinical lead roles. I know there are so many people in this forum groups. They go for further trainings in UK universities undertaking psychologically or mental health related training. So these are wonderful roles for them if you are a qualified social worker. And you've got the management role. So you can apply for team management roles, deputy managers, operational service leads, director roles. So these are the roles that open to social workers within mental health. So I'm just going to close that and call it a day now because it's you had a very busy, very in-depth information from different verses. But if you need any further information, feel free to come back to me. We'll be happy to share this. Thank you. And I invite CP Sebastian to briefly talk about the EDT and the ARM related roles and the, thank you.
Oh, thank you very much, Ms. Biju. Thanks for inviting me today's session as well. And I think, is it possible, Viju, you can share the slides I sent earlier? I won't take much time, in just a few minutes. We will mainly focus on EDT only, because I know people must be exhausted. 1 hour, 42 minutes gone since we started. So I will just briefly, are you able to share the slides?
Yeah, sure, yeah. I'm bringing that up now. Give me 1 second.
Yes. Thank you, Viju. Yeah, that photo is not me who made it. My cousin, I had told him to quickly make some slides. He put it that way. But because he put some emergency services, he put that photo, maybe that image. So basically, emergency duty team means I know most of the people who work in adult social care and other, they do make some referrals at some point at the end of the day or the weekend. Social care, a referral to emergency duty team for follow-up. Is that gone, disappeared?
Yeah, I just get it back. Give me 1 second. I think there is some issues with it. Sorry.
That's all right. So basically, you can make any referral to emergency duty team if you're concerned about a patient or their welfare or anything else. That's what it is. Emergency duty team is for. Next slide. Yeah. Maybe if I can't do it. Okay.
Yeah.
This is to address, emergency duty team is to address all the crisis referrals that occurs during out of hours. Means usually so many services are available during the day. At 5 o'clock, everything that you won't get through to anyone. So you have one single point of access, one number to call every local authority. I'm working for one of the NELF EDT, which is a super EDT I will call, because it used to be 4 boroughs, separate EDTs, though they merged together under their trust, and they made it one single EDT, which is a huge area to cover, in fact. So the social care and mental health, they make a referral to us. Because I'm an AMP, we have to deal with mental health and assessment as well. Next slide. And as you know, the time is weekend and after 5 o'clock, and the weekend until Monday morning. Who normally makes the referrals? It is police can, if they are concerned about any particular individual, police can make referrals, or the ambulance service if they are stuck with a patient due to social care, or mental health if they have a crisis, they do call the emergency duty team. And the nursing and care homes also, if they have any safeguarding or any other issues, they make referrals. Hospitals and A&Es, clients themselves can call if they need any sort of support out of hours. And even I have normally on Friday evening, I get a lot of referrals from anxious professionals who are finishing the job at 5 o'clock. Mr. Thomas would understand what I mean. Lots of referrals from mental health perspective and social care. We get the highest number of referrals I receive is a Friday evening, and not from clients, not from the public, but from professionals. And that means because they may be concerned over the weekend and they wanted some follow-up, that's why they make a referral. Then NHS 111, GP services, carers, members of the public. That comes basically if they have concerns about some sort of safeguarding, especially even the neighbors or relatives or anyone with anonymously, they make calls. If you are concerned about somebody in the neighborhood and you don't want to tell your details, they do call us, and then we, our social services, we need to make sure that that case is followed up. Normal response time is 30 minutes, because when I get a referral, we need to respond to that referral that we have received it, and then we, depends on the priority of the case, the emergency situation, we do follow up. Types of social care referrals, it's already mentioned. We have a children's emergency duty team, I'm from adult mental health and adult social care. So whenever I refer for the children's team, sometimes it comes to our attention. So we refer those cases to the children's team for follow-up. And adult, anything that you can think of, like somebody, the carers didn't attend, or no food, no medications. This is not supposed to be a role of the social worker, but still people do call. If they had a fall and they can get up, and they sometimes ambulance they can't reach, they can call the ambulance. They do call the social services, so they have pendant alarms. Lifeline services will contact EDT for follow-up or for more details. Bed mount patients is same. The key, because sometimes when patients, they do have a key safe outside fixed. And if they can't attend, suppose one of the social workers visit a client, or the carers visit client in the evening or out of hours or the weekend, they can get through to the client, they can access the key. They contact us. I mean, I'm just telling the different situation. Carers didn't turn up and they need urgent care or care package, and requires emergency care package in some situations, and needs carers to stay overnight due to family member being taken to hospital due to emergency, request emergency placement. Sometimes one of the family members is taken to hospital and the patient or the family member can't stay. If it's an elderly patient or someone with special needs, they can't be left alone. They do call us for emergency placement. In some situations, we do arrange a carers to stay overnight, or in extreme cases, if they need to be taken to a placement, then we do arrange that as well. Yes, please. Would you next slide, please? Other situations are disabled patients, as I mentioned, water leakage, flooding, fire, and they need rehousing. They still come to us, our attention. Sometimes crisis admission even happens, Mr. Thomas would know. Quite a lot of admission happens to A&E when there is crisis admission. Sometimes they don't need a medical need, but they are taken to hospital by ambulance. If one of the partner is taken to hospital, who is the main carer, they take the other partner as well along with them to hospital, because they can't be left alone, or no carers can be arranged in an emergency. Client not opening the door. Yes, just please go ahead. I'm always focusing on EDT. I'm not going to touch upon other things because we are running late of time. Mental health referrals. This is one of the main area, because we get a number of referrals, because we cover almost 4 police stations, 3 hospitals. Where the normal referrals comes from, community. If there is an emergency where the police and ambulance services are concerned, when they are attending a client at home, then they do contact mental health services. If the patient is either refusing admission or they need urgent mental health assessment, they do call on such situations. And then police station, we get a lot of referrals, because as I mentioned, we are covering 4 police stations, and 2 of them are super custodies with the 32 cells and 40 cells. And most of the patients around the area are taken there, either if they are arrested, and once they are in the custody, the FME or the custody nurse or there is a liaison and diversion team is there, who are from the mental health background. They do an assessment, and if they're concerned about this patient does need more input or need a mental health assessment, and then they make referrals to us. So that's quite a lot of referrals we get in part of my area. Yeah, hospital A&E, and some situations the police take patients on section 136. Section 136 is a special power of the police to take someone to hospital or any place of safety for further assessment. And while they are within, now previously it used to be 72 hours, now they're reduced to 24 hours. So once we get a patient on section 136 in A&E or anywhere else, we have to arrange an assessment with 2 doctors. Usually there's a process. There is an initial psychiatric liaison team will do an assessment, and then there is a duty doctor who assesses. And if the patient is informally willing for admission, then they want the AMP, the social worker, to come and assess jointly with the registrar, then make an informal admission. Whereas in situation where the patient is refusing admission, in those situations we have to arrange 2 doctors, section 12 doctor and another doctor, and the AMP, and then we do the assessment and we make the necessary arrangements for admission to hospital. Thanks, Viju. Yes, as I mentioned, section 136 patients is HBPOs, means health-based place of safety. That's where if a patient put on a section 136 to be taken to, where they'll be assessed. And there is a time limit, 24 hours, they should be assessed. That's the time limit. And then we do get referrals for section 2 mental health assessments. Section 2 is for normally an assessment for an admission to hospital if they need to be, for further assessment in hospital. That's the maximum period of stay is section 2 is 28 days. Just for your knowledge, I know only a limited number of social workers are for mental health. That's why I'm just explaining briefly. And referral for section 3 is mostly if a patient is already on an admission, past history of admission, they have a clear diagnosis, then when we assess, we really need to conduct the section 3 assessment, where the patient can be admitted maximum period of 6 months, but very rarely you keep somebody for that period, because last night I did an assessment, section 3, at the middle of the night, and the patient is still waiting for a bed. I haven't completed the application at the moment. Section 4 is an extreme emergency where you're supposed to assess a patient with 2 doctors. In some situations, you don't get through to a second doctor, maybe out of hours, maybe someday. So you still have to admit him and you can't leave the patient. Then you arrange with 1 doctor and the AMP, and assessment is completed and admitted. But within certain time, 24 or 72 hours, you do a reassess and convert into section 2. Thanks, Biju. Next. CTOs. Normally, we consider CTOs for patients who are already admitted under section 3. And if they really need a close monitoring and supervision in the community, and you want to discharge the patient from section 3, then you are likely to consider for CTO. CTO means community treatment order. It's a part of an extension of the section, but still attached with some condition they're discharged home, wherein they really need to stay in one particular place, and they need to engage with the community mental health services and comply with their medications. So they are discharged on a CTO. In those situations, if they breach any of these conditions, the RC means the responsible clinician, who is the treating doctor, can recall the patient if they don't comply with those conditions. A recall means it is now, for example, if a patient to do an assessment under section 3, it takes a lot of resources. So that bypassed, if somebody is on a CTO and you feel that patient is relapsing and needs admission, you can recall the patient back to hospital by serving a notice by the RC. And then you do an assessment within 72 hours with the AMP and the RC, and they can revoke the CTO, and then they automatically go back into section 3, which means a little bit of resources saving and easy for management as well in terms of community patients. Yes, Biju, next one. We don't have many more. Right. CTO recalls and revocation I mentioned already. Yeah, next one, please. Is the finish? Maybe. Section 117 aftercare. That's basically the local authority has a responsibility to provide support and care if they are admitted and they're discharged. That's briefly about. And next slide. And if I just a few points, AMP is a role at the moment. Anybody can become an AMP. If you are a nurse or you are any other profession, you are interested, you can. That's why approved mental health professional. Previously, only social workers used to be this role, and that used to be known as ASW. I was in fact started with as an ASW in 2005-06 period, and then later on they changed into AMP, wherein the profession is open to. This particular role is open to other professions like nurses and others, and psychologists if they wish to. I know some of my colleagues who are from nursing background have also trained as an ASW. And the AMP has got a major responsibility. I mean, Biju knows, Biju is an AMP, and any other AMPs in our team, I don't know. Basically, when a referral comes, this is a responsibility of the AMP, complete coordinate the assessment, getting the section 12 doctors. You need to have one doctor with the previous knowledge of the patient. Another doctor could be anyone, preferably section 12, means somebody with a training in mental health. And then the other crisis team, you arrange the assessment. You really need to speak to the nearest relative under the mental health bag. There's a specified list. You can't call anybody. Sometimes in some hospital record, they put next of kin. But next of kin need not be the nearest relative under the Mental Health Act. So last night, I had this Section 3 assessment at 12 o'clock, someone who's really unwell. I couldn't consult the nearest relative. Until I don't consult, I can't make the application as well. So this morning, although we tried to contact the family, we managed to only speak to the family today. So, I mean, that's very important. That's what I'm trying to say. So the arm's responsibility to arrange all this things, consult the family, arrange the doctors, and get the whole resources arranged and do the assessment. And one most important thing is that you have the veto power. In terms of, what I mean is that even if the two doctors recommend admission, and if you as an AM think that the patient doesn't need to be admitted, you can either say no, or you can put on hold, because you got 14 days period. And if you want to have a close monitor, I've done a couple of occasions where the doctors made a recommendation, completed the medical recommendation, but I thought that patient is complying and engaging with the treatment, so I didn't make an application. But this is a major responsibility. If something does happen, you are accountable as well. But still, it is a responsibility position where you can hold on to the decision. You can say no as well. That's what I'm trying to say. So anyone who wish to, from the mental health background, would like to become an AM, I would strongly recommend that. It's a very good role, but with responsibility. Anything else? I think my slides finished, Biju. I think I was working, I made it quickly. All right, thank you so much. That's all from me.
Hello, thank you, Sujata. Thank you very much. So now we've got 2 minutes literally, but I can have another 10 minutes if you want to have any questions, answers. I know it's a long session, but I hope it was good and able to give you a clear picture about how that social care system works in the UK. And that is purely what we are intended to provide you with today, because it will help you to formulate your thoughts on things when you apply for jobs. Like this is where you can get information about how the system works and prepare yourself for it. So if you've got any burning question, please feel free to ask here. Either you can unmute yourself and ask, or you can put it in the chat box. We've got another 5-10 minutes the most, because I know it's nearly 2 hours. So feel free.
I think everybody should be beware. If you have more than 23,250, you are not entitled. So make sure that your money is either transferred to me or saved. You are not entitled for social care.
Yeah. Thanks, Sujata.
That they have changed the policy a bit more now to say that if you own a property that you don't live in, previously it was like if you live in a property where even if you own another property, if you are still living at home, your property was not considered. But if you now live in a property, if you have a property that you don't live in, that is taken into account even for domiciliary care. For example, we have a case where the person moved to live with the daughter's property. He has no other property. He needs domiciliary care, but he owns a property elsewhere. And his intention is to live here. Therefore, his property, only property that he owns, will be taken into account for the calculations.
Thomas, what about the property in Kerala? If I got a chance, if I'm going for care, I think it will also into consideration, no?
If they know anywhere in the world, they will take into account.
So, the fact that you told us now, we are all aware now.
We all know.
Our people are put all their mansions picture in the Facebook, social media, and say, I have no property. All these things is going to be a huge impact. Okay, friends, see you. Bye.
We can alert Rishi Sunak and Jeremy Hunt. Thank you so much.
Thank you, friends.
You don't need to alert Rishi Sunak. He knows well how Indians work. So
So I think we need to sell everything and go for holiday.
Yes, that's what we have to do.
Like the English people do, yes.
Yeah.
By the time they will change the rule and the policies, because they might not have any money, so they will say,
yeah,
if you have money, you will have care, otherwise no care.
Yeah, That's true. So yeah, if you haven't got many questions, like I would like to say thank you to all the people who presented today. I know it was, a challenging task because we have to get everything arranged in a certain way to give sense to what we're doing today. Especially Susan for coordinating the first session, giving an overview of adult social care, and then Martin for giving that adult social care team perspective in terms of focusing on the Care Act and how the things are done in. And then to Thomas for the hospital discharge services and CB for the EDT and ARM service. And I'm sorry we couldn't complete the session on safeguarding today, which is one of the major sessions. And I would, as promised, we will have a standalone session for safeguarding later on.
I think so. It's a vast area, so it should be a better one. Single session on safeguarding would be more ideal.
Yeah, and unfortunately, Shibu had some technical issues as well today, but that couldn't be helped. So again, that was I would like to express my sincere gratitude to all the panel members for presenting today on behalf of the forum and on behalf of the resource team. And secondly, not last but least, you guys, who the people who joined today. To be fair, we had a quite large number of representations or registration today, but unfortunately, the conversion rate to participation is still remains 50-50. So we had about 95 registrants, but we had only 43 on the top of the registration, the participation list. Only had 43. So I don't know what is said about. So if you are, thank you for all who joined today, and thank you for showing interest in the CPD sessions and the sessions that we conduct. If you have got any specific areas that you want us to focus on, please let us know, because we are, to me, from our point of view, all these the panel members, we are all, we came to the UK around 10-15 years ago, at least. So the needs at that time was different to what is now. So if any especially areas you want us to focus on, let us know. And any like I said, as Thomas said, the next session we will be focusing a little bit on registration process as well, so that those people who wanted to get registered at Social Work England, we will be able to support them with. We're also looking for people who done registration recently. So the process better than us, because I registered as a social worker in GCSE, General Social Care Council, and that was in 2005. So now it's around 20 years now, isn't it? So so it might have changed. So so if he could join us to give that advice, it would be great. So if anybody could join us and give it, it'll be fine. We'll let you know. Also, the presentation slides will be shared with you only with those who are participated today. And if you need a CPD certificate from us, let us know. I know there are some people who asked for a CPD certificate from last seminar, which I will be sending out soon, because we are just in the process of developing a new template. So once that's done, I'll share that with you. Okay, so thank you once again for all your time and effort today, and wish you a wonderful rest of the weekend, and enjoy the sun as well. Those who are in the UK, that's a very rarely get a chance to enjoy the sun. And those who are in Kerala, I know you always get it, but I don't know whether you started having rain now. So if it is the rainy season, enjoy that as well. Okay, thank you very much.
Thank you very much, Biju. Thanks a lot. Thanks, everyone.
Thank you.
Biju, are we staying back?
Maybe just for a few minutes, and then we can enjoy the sun after.
So Susan is there, isn't it? Sibichatan, do you leave? Susan is here. Thank you, Susan, for coming back. I know you had a busy day. I'm really sorry.
It's okay. It's okay.
So sometimes I get a bit persuasive, isn't it? Like I'm just pressurizing people to do things. But I'm sorry.
No, that's absolutely fine.
Yeah, is any the next session is, we'll be focusing a little bit more on, like we'll do the safeguarding, and we'll also try and combine the registration with that. Is that okay? If we
I think that's a good idea. Maybe the next session. So we have one session on our theme. I mean, like educative session and one informative session, like both together. If we can combine,
yeah,
maybe we need to maybe get one or two people. Of course, we know for safeguarding we got the person ready. If we can get one or two people for the recently registered people for the registration process, because it will be more of a question answer session. People will be asking what's the process and any issues. They may be able to better answer than us, because we are only just renewing the registrations these days.
And I'm also happy to support as well. So
okay. Yeah. So Smriti is just asking a question. So I know, Smriti, I don't know whether you want me to answer here or you want to send. Yeah. Whatever. Are you in the UK now, Smriti? Or okay. So sorry guys. I'm just answering to Smriti. So it's going to be a bit weird for you. Okay. We are offering registration only to people who are currently in the UK. Who have got a social work registration or undertake any social work qualifications, but you're happy, you're happy to come and join us for the sessions and things. That shouldn't be a problem. If you want to take advantage of your, like our forum things, you can always do it. Yeah, is that okay?
Yeah, we always share with the with the CAPs, and also they can always join.
Yeah, that's it. Okay. Yeah, sorry.
Right. So probably we can enjoy the sun for the rest of the day. And I think it was a very good session. Maybe we had a little bit of a short of time for questions, but we still left it open. So people didn't have any questions, but so
yeah. But end of the day, there's a couple of things, like we wanted to cover the adult social care structure as a whole, so which is we done. But like we couldn't cover all the specialist areas and things, which is never going to happen anyway.
Yeah.
Every day they've got something new teams coming up. So which is not going to be happening. But anyway, we could give that kind of a brief overview. That's a great thing. So you've done very well. Thank you very much. Susan, Martin, and so
and I think we have sun across UK today, so let's enjoy the bit of
enjoy the sun as soon as
let's not lose the vitamin D that we can get now.
Yeah, the only thing is you enjoy the sun as long as it lasts, so you don't know what's going to happen tomorrow anyway. So
even tomorrow is good, I think.
Also try not to get the sunburn.
That's true. Yeah. Okay, so thank you very much.
Thank you. Have a great evening.
thank you.
Bye.